which extends all the way from bone to skin. This is defined as this portion of the infraorbital groove or sulcus, which extends to the mid-pupillary line. Lateral to this is a bilamellar structure which is called the orbicularis retaining ligament. This shows externally as the palpebromalar groove, and this retaining ligament has a dense attachment that also again extends from the bone to the skin, thus causing a visible depression. The tear trough ligament and the orbicularis retaining ligament are also consistent with the division between the orbital portion of the orbicularis and the palpebral portion of the orbicularis muscle. When injecting in these areas, when we are lateral out in the zygoma, we are injecting on a pre-periosteal plane. When we are injecting in the medial maxillary region in a space called the premaxillary space as defined by Mendelssohn, we are injecting deep to the orbicularis in the souffle layer or above the layer of the elevators of the upper lip. In the actual groove itself, which is the tear trough and the palpebromalar groove, we are injecting more in as deep a level as we can, but we are injecting right into or through that ligament, as we are not able to get above the ligament because the ligament extends all the way from bone to skin. This is where we must be most cautious with our treatment in order to avoid prolonged edema, overcorrection, or Tyndall effect where there is minimal skin coverage in this region. In order to treat the infraorbital hollow, we are going to address the structures that enhance or accentuate the hollow first. This includes elevation of the zygomatic or lateral portion of the cheek, as well as the medial portion of the cheek. By doing this, we are aiming to improve the support surrounding the tear trough and the orbicularis retaining ligament to minimize the depth of the fold, as well as to elevate and reduce the distance between the lid and the cheek. By doing this, we need less product, and hence we'll have an easier time of improving the actual groove itself with less risk of complication. It is important to have the patient understand that correction of the infraorbital hollow is typically treated to a correction factor of 70 to 90%, not 100%. This is in order to reduce the risk of post-treatment prolonged edema. Secondarily, we need to point out to the patients what aspects of the hollowing is able to be treated. The hollowing is secondary, obviously, to volume loss and descent of supporting structures. However, additional components that create further shadowing in the eyes include pigmentation, such as seen in this patient, as well as the venous distribution along the margin of the orbit, which also are not improved by hyaluronic acid treatment alone. Our treatment points consist of lateral injection sites along the zygoma in order to elevate the lateral cheek, and then an insertion point with a cannula that corresponds to a line drawn vertically dropped from the lateral canthus in an intersection with the alar groove. This allows us to access all the points of the orbital hollow and infraorbital rim. For this treatment, we are using the Bellotero line and starting with Bellotero volume. The first injection point is laterally. It roughly corresponds to the temporozygomatic suture line, and a bolus of approximately 0.1 to 0.3 cc's are injected in careful fashion. The injection depth is right at the level of periosteum, and our more anterior point is at the level of the malar eminence. Again, the needle is introduced right to the level of the periosteum, and a slow and deliberate injection is performed. In this case, 0.3 cc's are injected into the more anterior injection point on the cheek.